So this is Dr. Bruce Lipton, and he speaks about the biology of belief. We will go ahead and look at just the first couple minutes because I want you to hear what this is about. So we both validate and affirm, but we also help them reframe cognitively distorted beliefs. So yes, it starts with cognitive work. That's not all there is to it, but it starts with it. So it's important to remember this, especially when we're talking about complex PTSD. Some researchers have argued that personality traits may account for re-exposure to trauma, suggesting, for example, that personality traits related to impulse control may be associated with increased probability of encountering a traumatic event, and that borderline personality may represent the same risk factor among women that antisocial personality does among men. This is the idea that's been put forth. Given that experience, and this is a paper that was done by 2 women for the After the Crisis Healing from Trauma After Disasters panel meeting, says, given that experiencing trauma is a known risk factor for eventually being designated with the diagnosis of antisocial personality disorder or borderline personality disorder, this line of research seems to constitute blaming the victim of the very worst kind, namely blaming the victim in the name of science and bolstered by so-called scientific findings. So this is what we find, is that when we say it's personality traits and genetics, we say that it's untreatable, and we say that the person is just willful. I just can't understand it, quite frankly. If it's personality traits and it's genetics, the person's willful, it just doesn't make any sense, but that's how it's put out there. So I am going to skip over this next video, but it's a lovely little video of a compassionate view of borderline personality disorder, and with some interviews and a PhD therapist in San Francisco. So if you want that resource, you can just write her name down. It's Tamara Sattler. It's important for us to notice that the DSM makes a lot of money for a lot of people. And let's see where it is. It says, not many people know how powerful and influential the book came to be. Here's a brief look at the evolution. But there was still a need to gather uniform stats across mental hospitals. And so in 1917, the Bureau of the Census embraced a publication called the Statistical Manual for the Use of Institutions for the Insane. So that's how we got this. No wonder there's stigma. And so the DSM was born, deviating markedly from those accepted by the individual's culture. Just think about this. I like to think about who came up with this. Who were the white guys in white coats sitting around being annoyed by women and some men that they didn't like, and they didn't want to figure out or care to figure out where it came from. So they come up with these personality disorders. Think about it. If you've been given a diagnosis that's you're told is inflexible, that's your diagnosis. It's part of your inherent personality. It comes up in the teens. It's not determined by any scientific lab test, but it's untreatable. When you want to know who came up with this, who are you, wouldn't you have an attitude about it? I certainly would. So we need to remember what some other people say. These are 2 medical doctors, psychiatrists. Vessel Vanderkolk says, if you've been raped and abused for years as a child and adult, your entire organism and personality has been organized around your trauma. The way they act is understandable. They're not just people trying to make your life miserable, but people trying to survive. Colin Ross says, I view borderline personality disorder as a normal response to chronic childhood trauma. Okay? So we need to figure out what's our view going to be. Because we're dealing with people who are hurting. It's just like, when little kids get sexually abused and we have all this compassion for them, but then when they get to be teenagers with hormones and we get afraid of them and they start acting out, then what do we call them then? Offenders. And all that happens is they grew up a couple of years. There's a fine line in there. And so we have to figure out what's our viewpoint going to be, because that's going to determine how we go forward in working with people. So, while the DSM has been praised for standardizing psychiatric diagnostic categories and criteria, it's also has generated controversy and criticism. Critics, including the National Institute of Mental Health, argue that the DSM represents an unscientific and subjective system. This is one of the things I've always thought is so subjective. Who says? And some of the words even. Now, especially when you think about cognitive therapy is kind of a given in our world, right? And when you think of all the labeling that they use and the subjective words that they use that are in direct contrast or opposition to what you would teach someone in cognitive work. So the experts are labeling people. It says there are ongoing issues concerning the validity and reliability of the diagnostic categories, the reliance on superficial symptoms, the use of artificial dividing lines between categories and from normality, possible cultural bias, medicalization of human distress. All these are issues that are inherent with the DSM. And believe me, I understand you're working in settings where you have to use it, and although soon it's going to be the ICD. The ICD is a little better with some of this stuff. It says the publication of the DSM with tightly guarded copyrights now makes APA, the American Psychiatric Association, over $5 million a year, but historically over $100 million. So think about that. It's a product that gets produced and sold. And we accept it like it's truth. It's a book written by a bunch of people. And this new one, if you've read about any of the controversy, I signed a pledge with the American Psychological Association not to buy one. So, is it borderline or something else? And I say use your compassion and your curiosity. We've got to keep our curiosity open. And what do I mean by compassion? Do I mean condone poor behavior? No. We can't let puppies run around biting people or biting themselves, right? But we got to do something to help them. We don't just throw them in a corner and say, go away, hopefully. So this is Dr. Vessel Vanderkolk. We'll listen to him for a few minutes. He's done amazing work. So he actually has proposed, as I said, 3 diagnoses. We're going to focus on the complex PTSD. That includes ongoing circumstances and events, sub-threshold events and circumstances that the person has an inability, real or perceived, to escape. There's physical and or emotional captivity. They have, as a result of their experiences, emotion regulation difficulties, distress tolerance difficulties, re-victimization often, difficulty in interpersonal relationships. Their consciousness is changed. There's a fragmentation that may happen with some people, so a dissociative process. There's self-esteem issues. A view of the perpetrator gets developed that's particular to them, and there's a view of relationships in the world that's particular. So we're going to talk now about what I view as, this is what trauma response is. What I view as, this is the foundation. Everybody needs to understand this wherever they are, these 2 concepts that I'm going to talk about. I first learned about these concepts when I read Colin Ross's books on trauma, and then I went and did my practicum for my MSW in Dallas, Texas with Colin Ross, and he called them something different than what I called them. I call the first one internalized blame of self, or IBS. If you know what medical IBS is, it's because it's a lot of crap to deal with when you start actually seeing it in yourself and dealing with it. And then he called this other one ambivalent attachment to perpetrator. I think Stockholm syndrome, okay? But I saw in my work, as my work went on, especially in private practice, I saw people ambivalently attached to themselves, to their education, to their work, to their relationships. There was this push-pull going on all the time for them. So with IBS, it explains the self-blame, low self-esteem, self-sabotage of survivors, and informs us why it's difficult for our clients to accept that it wasn't your fault. Every good therapist says it wasn't your fault. Okay, we all know to say that. But there's another step. Understanding this concept and how it shows up in our clients' lives gives us increased compassion and patience, whatever our setting or role. Because sometimes this stuff shows up in real ugly ways. We've been working with the client for 2 or 3 years maybe, and they've been doing well, and then all of a sudden they start cutting on themselves. And the way they let us know about it is kind of not real direct, let's say, right? We could get caught up in judging that, or we could see, wow, your IBS is coming out. What's going on? And we can make it a therapy issue and work through something. Ambivalent attachment explains the help me, don't help me, push-pull syndrome that elicits these phrases. They're manipulative, or he just wants attention, or they're needy, or they're entitled, all those ugly things that we've heard. It's a core issue for complex PTSD and so-called borderline personality. Accepting that this behavior is not personal helps us refrain from unproductive power struggles and extend increased compassion. So again, there's balance with it. I have compassion for you, and I'm going to hold you accountable. These are very often the clients that you get to the end of the session, and they bring up a totally new subject. I've actually stood at the door and said, kindly, it's the end of your session. I can't get into that right now, but you are sure welcome to call me and make another appointment if you want to this week. I'm not shaming the person, but I'm setting the boundary, and I'm not going over my session with that person, showing them poor boundaries, and then making the next person's session late, and then me go to lunch later and resent that person. So by me having that tool and setting that boundary and being compassionate about it, I recognize this is a trauma response. It gives me that tool. So we're going to talk about these in turn. So IBS is a self-blame developed as a coping skill. Self-blame was a helpful defense as a child, but in adulthood it gets in the way of life. IBS is a foundation of treatment, and working with it will empower the client and create a progressive environment for therapy. Very often, I actually talk to people the very first day I see them, very first time I see them, because people are expressing, I'm just an idiot, I'm just sick, I'm just crazy, all that low self-esteem labeling. And if it's conducive, and very often it is, I start drawing little pictures and showing them how this works, and people usually go, yeah, that makes sense. At the same time, IBS makes it all about me, because people get stuck in childlike ways of viewing themselves and viewing the world, and that's where the annoying behavior comes from, but they don't know they're doing that. They're only doing what they did to survive. And so it's my responsibility to educate them about this, to talk to them straight about it versus behind their back. So they make it all about me in ways that they might not even be aware of, and it affects their communication, their relationships, and their accomplishment of goals. So here's what I call a trauma-aware professional. A trauma-aware professional says, it wasn't your fault, or you. Okay? The trauma-informed professional understands that self-blame was used as a coping skill and says, it's not your fault, and here's how believing this helped you survive. But now here's how it's getting in your way, and this is what we can work on. Magical thinking is the only thing little children have, or egocentric thinking, as Piaget called it. Causal reasoning, it's causal reasoning that looks for correlation between the actor or the utterances of certain events. A 3-year-old will go, it's raining because I'm sad. Because what do we know about child development? Their world is all right here. It's all about me. It's supposed to be, okay? The outside world is linked with the child's internal consciousness. You're hurting me, so I must be bad. I'm bad, so you hurt me. So that's what gets set up in this child. Children don't have the intellectual capacity to challenge their own magical thinking. They believe they're the cause of events happening in their world. Our brains are not fully developed until we're in our early 20s. There's lots of really good research now that establishes that. When the adult survives all this, whatever it is, in the face of overwhelming feelings and new events and relationships and circumstances, they resort to magical thinking in order to gain a sense of control and avoid feeling completely vulnerable in a seemingly unpredictable world. So they fall back on what worked as a child. So here's how it works. Mary's 4. At night she hears her parents fighting. Daddy yells at Mommy. Her room is always messy. One day Mary comes home from preschool and Mommy tells her, Daddy's not going to live with us anymore. What does Mary think?
Because her room is messy.
Yep, it's my fault. My room is messy. Nobody gets that mad. 4-year-olds get that right. 80-year-olds get that right. Nobody gets that wrong. Okay. So is this really the reason Daddy's leaving? No, what's going on? Adults are having issues, right? Adults have issues, so the adults are having issues. So, Mary's only resource, though, is magical thinking. She can't figure out, oh, mommy and daddy are having problems. This doesn't have anything to do with me. She thinks it's all about me. So what does she do in order to cope with this? If we didn't have this, we would have millions of children that look like they're autistic because we'd all just shut down. And that does happen once in a while. But how does it help her cope? Maybe if I clean my room up, good enough. Ever heard anybody talk about not being good enough in therapy? Heck yeah, all the time. Daddy will come back. So in this way, she takes responsibility for the adult's actions. Hope gets created. Maybe I can do something about it. So she starts to believe erroneously that she can control people and environments. And sometimes if daddy comes back on the day her room is clean, oh, maybe she, I did it. But if he doesn't, then she keeps thinking I'm not good enough. I am not doing it good enough. So the adult has all these resources. The child has magical thinking as a resource. Now, I've had a couple people tell me when I was 4, I did figure out it was my adults and I ran away. I said, so what happened? They took me back home. I said, yeah, because you can't go rent a house, buy a car, get a job, take care of yourself. Even if you could stand there and say, hey, Dad, you're screwed up, quit hitting me, go get some therapy. You can't do all these other things. So this is part of therapy. This is part of how you work with this. When the adult gets stuck in this magical thinking, sabotages themselves or thinks I'm a loser or whatever, you remind them, what are your resources right now? What are the resources you're using right now? You're coming to therapy. You start with whatever's there in the room with you. And you help them start to shift and mature and see, oh, I'm an adult now. And what will happen when people really get this, they'll start coming in and they'll go, oh, I had an IBS moment. I caught myself doing this and I changed and I did this and that. So because of brain development, social, educational, physical, and economic opportunities are not available, magic thinking is the child's sole resource. Especially if the perpetrator is reinforcing, I'm hitting you because you're a brat. Well, that just reinforces it all. Okay. It gives a sense of control because I could be good enough by good grades, working hard, being sexual, pretty, funny, performing in various ways, and maybe you won't hurt me and you'll love me. Aren't these some of the basic issues we work with in therapy? My dad didn't love me. I've got 3 master's degrees and I'm still not good enough for my dad, right? So what do we tell them to say? Oh, use positive affirmations. I am enough. Great. But guess what? When you're stuck in this, you're not going to be able to do that because it's not going to feel right for you. So this is an article that is in your resources, I believe, and it shows that there's actually, when somebody has a broken heart out of a romantic relationship, there's actually a physical, chemical thing going on in the body. We have physical pain. And the article talks about a research study where they actually used Tylenol. And Tylenol actually, for a short time, relieved the pain, and so did getting more support. But the thing that really relieved the pain was a romantic relationship, another romantic relationship. But there's actual physical pain. Think about how we're walking around when we're children, when we're stuck in this self-blame. When we use cognitive therapy, what do we say depression is about? Depression is about lost. We feel we've lost something. Well, what happens in childhood? When you go through neglect or abuse or perceived, we all have our perceived little things, right? We have a sense of loss. Our heart gets broken. We're walking around in physical pain, and then we're expecting children to, sit in chairs all day for 8 hours. So it's just an interesting article that I thought really kind of fit in here with the whole fact that when people go through these things in their very young years, and then we look back on it with an adult eye, we have this adult eye, and we forget what that little child went through. So now Mary becomes a person who's constantly striving to be good enough, pretty enough, smart enough, clean enough, strong enough, rich enough, whatever. This doesn't work out well in adult relationships, and grown-up Mary relies on her magical thinking rather than become aware of the many adult resources she now has. This can be annoying to people because people will act helpless. It's like, well, you have a car, you could go do this or that, because they can't see it. And so part of our job is to help them remember, these are the resources, to ask them, write down, what resources do you have? What can you use? What are you using? She often responds to adult situations with immaturity, exhibiting a self-centered, so-called helpless personality rather than an empowered identity. So here are some expressions that I've heard. One was from a school teacher who worked in the very same area that she'd grown up in as a kid, and she was now a school teacher. And I knew a little bit about school because of going to IEP meetings for my autistic son and so forth. And so she says, I should have gotten A+ on my report cards. I said, can you give A+ to kids on your report cards? Because usually the scale only goes up to A, right? She goes, no, but I should have gotten them anyway. This is how illogical it becomes. Here's an educated person that is accomplished. She's got a career, and yet she can get stuck in this immature, childlike reasoning that I should have gotten A+. It wasn't possible to get A+. So people put these impossible, not good enough standards on themselves. Child reasons, if I'm good enough, maybe you won't hurt me. The adult explains it. So this is what we all do, even if we didn't have any abuse. Especially, I remember years ago when I was still here in Iowa, there'd been a big tornado and it wiped out a little farm town. For some reason, nobody got hurt. And on the news, people were going, well, if only we hadn't built our house in that field. So we do this thing as a way to get a sense of control in an unpredictable world. It's a very human thing that we all do. But again, when victimizers say, you made me hurt you, they reinforce this illusion that the victim could prevent the abuse by being good enough in some way. It gives the child victim an illusion of control and a sense of power, though false, allowed the child to survive and to make sense of circumstances that made no sense. Understanding as a coping defense is vital to treatment, in my view. Saying it wasn't your fault, while comforting, does not address how continued use of IBS in adulthood inhibits recovery. The primary reason that an adult continues to engage in the use of IBS is for the avoidance of feelings. Because the kid had to put away all the feelings of hurt and anger and confusion and betrayal. And now the adult is like, keeps on with the IBS, the blame of self, in order to avoid all those feelings. This is why somatic work, experiential work, artwork, music, all these things are great after we do some other things. So lifelong effects. It's supported by ongoing cognitively distorted beliefs and thoughts and an inability to recognize their adult resources and accomplishments. The self-sabotage creates a vicious cycle of reinforcement of irrational, magical thinking that I'm bad and I don't deserve a good life. Victims unconsciously seek out relationships and job situations, for example, that seem to prove the truth of their low self-esteem. I'm just a loser. I can never have a good relationship or a good job or a good boss or whatever. When adults become parents themselves, they may unintentionally create the next generation. You can hear the language. Because if I don't have compassion for myself and I'm going to put myself down, guess what I'm going to do with my kids? It's going to come out of me somehow. So this is how you reverse it. Cognitive work first. You've got to deal with those cognitively distorted beliefs and ideas. Expressive work with education about, I talk to people, I tell them exactly what I've just told you. I explain it to them. This is how it works. People like that for the most part. And even when people don't really latch on to that, it always informs me. I believe that if people who worked in hospitals understood this, they wouldn't personalize those interactions between themselves and clients. They would go, oh, this is an IBS moment for that person. It's not about me. The therapeutic relationship is very important, and then eventually the use of positive affirmations. And I have people pay attention to how they react when they say those positive affirmations. Do you then go immediately and put yourself down? What do you feel in your body? What's the next thing that you do? So just positive affirmations are not magic. Who of us haven't had some of those moments? I say all of us are a little borderline because of the kind of culture we grow up in. If you can't claim your own, then don't work with people who have it because you're going to get really annoyed. So you gotta claim it to deal with it, and it's just part of our culture. But some people have really gotten extreme versions of it, and they're in pain. And I really like Maggie Eastep. She puts these things into poetry and music. There's a very raucous musical version of that I have used with clients, and when I choose wisely, which I usually do, they really like it and they get it. So this is what happens in ambivalent attachment. And it's necessary to attach to a caregiver for survival. We have to. The caregiver sometimes often offers love and sometimes rejection and neglect and abuse at others. So what's the child to do? Our brains can't figure that out. They can't figure out this polarity. So then the person becomes an adult and they can't conceive a dialectic. They can't conceive, you're mad at me and you still love me. They can't conceive that. You're mad at me, so you hate me and I must leave, or you have to leave. So that's part of the stuff that goes on for them. And we're getting a little close to lunch, so I'm going to cover a couple more of these, and then we're going to finish the rest of this one up at the beginning of the session after lunch, because these are the important things. These are the things I really came here to tell you about. All right. So this is Dr. Dan Siegel explaining what happens in attachment. Just gave us a very good explanation of how this push-pull attachment, this ambivalent attachment style can develop, even in the absence of outright abuse or neglect, a very nervous or anxious parent. Now, this is not going back to the days, and remember, I'm the parent of a person with autism, so I don't like that cold refrigerator mother theory. That's not what we're saying. But we are saying there are effects of things. So again, it's not that blame and shame thing. It's not, okay, that's where we stop, it's the mother's fault. No, that's not what we're saying. But we do say that there is an effect. Even a young mother who's very anxious and maybe she grew up with very critical. I've worked with people that have this stuff who never explain or never describe any outright abuse or neglect to me, but maybe they had a very critical person in their life that they're hypersensitive to. There are genetics involved in this. And so I want you to keep that in mind, that that's not what we're saying. But I like his explanation because it's not always about the person's been horribly abused. Very often it is, unfortunately, but it's not always. It's about attaching and how we attach and what's present in that attachment process.